Welcome back, guys. We're going to talk about SARS-CoV-2 in this section. In last section, we'll talk about SARS-CoV-1 and MERS. Here we will do 5 questions. This video is also recorded in the month of August. I will try to give you the latest guidelines from CDC. We're going to talk about 2 concepts here. Transmission of SARS-CoV-2, which causes COVID-19 infection, and prevention. SARS-CoV is the name of the virus and COVID-19 is the disease. Okay, so let's go to question number 207. Regarding transmission of SARS-CoV-2, which of the following statements are true? Okay, option A, droplet containing SARS-CoV-2 can remain viable on plastic and stainless steel for 10 days, suggesting infection could occur by fomite transmission. Option B, washing hand with soap and water for at least 10 seconds will completely remove virus particles from the skin, preventing viral transmission. Option number C, concentration of SARS-CoV-2 RNA in upper respiratory tract specimen decline after onset of symptoms. Option number D, there's a strong epidemiological evidence to support SARS-CoV transmission via fomite compared to transmission via droplet. So out of these 4 options, the right option is option C. Okay, so let's talk about option A first. Why option A is incorrect? Droplet containing SARS-CoV-2 can remain viable on plastic and stainless steel for 10 days. This statement is false. So let's go to next slide and discuss median half-life of SARS-CoV-2 on various surfaces. Okay, so median half-life in aerosol is 1 hour. We'll talk about what aerosols are in next couple of minutes. On stainless steel, it's 6 hours. It can stay there for up to 3 days, not for 10 days. Okay, on plastic, 7 hours on plastic, not 10 days. It can stay up to like 1 to 2 days, but median half-life is 7 hours. And on cardboard, 24 hours. Okay, so our first option was incorrect. I gave you option of 10 days. That was incorrect. Okay, so let's talk about hand washing. I gave you option of 10 seconds. So you have to do hand washing for at least 20 seconds. So let's talk about hand washing. Make sure you wash them for at least 20 seconds if you are using soap and water, and for at least 20 seconds if you are using hand sanitizer. When you use a hand sanitizer, you have to use it until your hands are dry. Now, effective hand sanitizer should contain at least 60% of alcohol, and if you're using isopropanol, it should be 70%. Okay, that will kill all coronavirus and even some of other germs. Okay, so let's go back to our question number 207. Our C option was concentration of SARS-CoV-2 RNA in upper respiratory tract decline after onset of symptom, and option D is there is a strong epidemiological evidence to support SARS-CoV-2 transmission via fomite compared to transmission via droplet. This statement is partially wrong. We have a strong epidemiological evidence that SARS-CoV-2 is transmitted via droplet as compared to fomite. Okay, although fomite do play a role in transmission, especially in healthcare setting, especially in close proximity, but the evidence for droplet is stronger as compared to fomite. So let's go to next slide and go back to our graph which I discussed in last section. So the first point is the viral load peak in the first week of infection and decline thereafter gradually. So if you see from -5, as you go to within 5 days, the virus load is maximum within 5 days of symptom. So it is highest infection potential just before or within 5 days of onset of symptom. After the onset of symptom, the virus load keep on going down. Okay, so our option C was correct. Okay, now here if you see this red dot, antibody response, the antibody response gradually increase and is often detectable by day 14. We will talk about antibody serology in next section. Okay, so after 2 weeks, if patient who have mild to moderate infection, who are immunocompetent, they should start developing antibody. Now, few studies have shown patients who are immunocompromised, they keep on shedding virus even for like 20 days. And if you check their serum after 2 weeks of onset of symptom, you might not find any antibody in their serum. That makes sense, okay? But in a patient who is healthy, who is immunocompetent, who has mild to moderate infection, typically you can see antibody after 2 weeks, and their viral load keep on going down after 5 days, okay? Viral load is the amount of the virus in 1 ml of body fluid. And the more viral load you have, the more patient is more infectious or contagious, okay? So the highest infectious potential is seen just before or within 5 days of symptom onset. This point is very important, okay? So let's go to next slide and talk about transmission. Majority of cases are spread by asymptomatic or pre-symptomatic individual when patients don't even know they are sick, okay? Studies have shown 15 to 45% of all SARS-CoV-2 infection, they are asymptomatic. That is the main reason we are unable to control COVID-19 infection as compared to SARS-CoV-1 and MERS-CoV, okay? A review of 7 studies have shown that there is a little or no difference between viral load in asymptomatic, pre-symptomatic and symptomatic patient. But few latest articles have shown the viral load is higher within 5 days of symptom onset, okay? So some studies have shown patients who are pre-symptomatic or asymptomatic, they are as contagious, as infectious patients who are symptomatic. Now, last point on this slide is viral load in the nasopharyngeal region. It may range from 641 to 1.35 multiplied by 1000 copies per ml, depending on the severity of the illness and number of days since symptom onset. Now, this viral load in the nasopharyngeal region, it will keep on going down after first week of illness, and after 2 weeks, in an immunocompetent host, you might not be able to detect it, okay? So we're going to go to next slide. We're going to talk about 3 primary vector for transmission. First is via droplet. Droplet are typically classified as a size more than 5 micron, and the larger the droplet is, it has more viral load and it will travel less distance, okay? So the droplet which are 10 to 20 micron, they usually don't travel more than 6 feet. They tend to fall with the gravity with their own weight. But droplet which are larger, 10 to 20 micron, they are the largest source of new infection. So this is the point number 1, droplet. The second is aerosol. What are aerosol? Aerosols are less than 5 micron. They can travel even beyond 6 feet, okay? And they do have a significant number of viral particle, okay? So we'll talk about aerosol in detail. I have one question, okay? So the third source of vector is fomite. What is fomite? Fomite is a inanimate object which has become contaminated with viral particle. We have weak epidemiological evidence. Out of these 3 vectors, the strongest evidence we have is the droplet infection is the main source of infection, okay? So let's go to next slide and discuss this picture. So in this picture, if you see the droplet, the blue one, these are typically more than 5 micron, maybe 10 to 20 micron. They tend to fall because of their weight, because of the gravity within 6 feet. These red dots, these are aerosol. They can spread even beyond 6 feet. That can cause airborne spread. They can stay in the air for longer duration. Now, droplet can stay in the air for a couple of minutes, Aerosols can stay in the air for a couple of hours, but the median period is around 1 hour for aerosol, couple of minutes for droplet. Okay, so we'll talk about this in detail in next couple of minutes. So the risk of SARS-CoV infection varies according to the amount of virus to which a person is exposed. This is a very important point. Now droplet, they are large, they have large viral particle. So if you inhale droplet, your chances of getting infection is higher. Okay, so the dose of the virus you get from droplet is significantly higher as compared to aerosol. The other problem with the aerosol is it can go directly to your alveoli and can cause significant lung infection in patients. Okay, we'll talk about that too. Now let's go to next slide and talk about SARS-CoV-2 virus. Now the size of the SARS-CoV-2 virus is 0.1 to 0.125 micron. One important point, the virus cannot exist as a viable single particle. It needs a carrier, usually other droplet, for more than 1 micron in size. Okay, that's point number one. Point number two, the amount of genetic material necessary to initiate infection is around 10 to 1000 virus particles. So if you have a droplet which is 10 micron, that might contain up to 1000 viral particle. And if a patient who have coronavirus, if they sneeze, they cough, and they make multiple droplet, your chances of getting infection are higher. Okay, now for SARS-CoV-1, which happened in 2003, we needed approximately 280 viral particle for transmission. So let's go to next slide and talk few definition. So first definition is small particle. Size less than 5 micron. They are aerosol. They can readily penetrate the airway all the way down to alveolar space. Okay. Now this point is very important. GGO is ground glass opacity observed in cat scan. Now in some studies have shown patients who are in healthcare setting and who are dealing with COVID-19 patient, and they can have infection with aerosol, and these aerosol can go directly to their alveoli. You can do a CAT scan even before they become symptomatic. You can see ground glass opacity on your CAT scan, on their CAT scan. This is typically seen in patients who are in healthcare setting. Okay, although aerosol transmission can happen in the community, in a closed setting, in an elevator. Okay, so let's talk about second point. If the aerosol size is less than 10 micron, it can go below your glottis. 5 micron can go directly to your alveoli. Large droplet, more than 20 micron, they are too large to follow inhalation airflow streamline. If patient wears surgical mask or cloth mask, you can prevent that. So 20 micron, they are heavy, they have high viral load, but they cannot travel further. They cannot travel more than 6 feet. They're gonna fall because they are heavy. They're gonna fall against the gravity. Third point, what about intermediate droplet, which are between 10 to 20 micron? They share some property of a smaller particle and some property of larger particle. They can travel beyond 6 feet, very, very unlikely. Okay, and they will give you a little bit smaller infectious dose as compared to particle which are more than 20 micron. Question now, let's go to next slide and talk about question number 208. All individual should use contact, airborne, and droplet precaution before entering a room with a patient who has confirmed COVID-19 infection on high flow oxygen and getting nebulizer treatment. This statement is true or false? This statement is true. Let's talk about this statement, very important. Let's go to next slide. So there are 14 procedures which can generate aerosol. I'm going to read all these 14 procedures which can generate aerosol, which are less than 5 micron, which can stay in the air for a couple of hours. Okay, median time is 1 hour. Okay, so first procedure is bronchoscopy, second is CPR, third is filter change on the ventilator. The fourth is high flow oxygen, which I have given in my question. Fifth is manual ventilation before intubation. Sixth is nasal endoscopy. Seventh is non-invasive ventilation BiPAP. Option 8 is open suctioning of airways. 9 is tracheal intubation and extubation. Option 10 is tracheostomy. Option 11 is upper endoscopy. Option 12 is if you're doing speech and swallow evaluation of the patient. Option 13, point number 13 is chest physiotherapy, and point number 14 is nebulizer treatment. So these 14 procedures, if patient is getting and patient have COVID infection, the healthcare worker should do wear an N95 mask. They should have contact precaution. They should have airborne precaution. Okay. So most of the patient in our hospital, when I'm taking care who have COVID-19 infection, these patients are typically on high flow oxygen. So most of the time in our hospital, we wear N95 mask. Okay. If patient is not getting these 14 procedure, you can get away with surgical mask. Okay. The risk of generating aerosol is very, very low. Now, what about eye protection? In our hospital, all healthcare workers have to wear eye protection, but the transmission of virus from conjunctiva or from eyes is less as compared to nose and mouth. The evidence is weak, but in our hospital, we do wear eye protection for all COVID-19 patients. Okay. Now, let's go to next slide and do question number 209. Which type of face mask does the CDC recommend for the general public to fight COVID-19 infection? Option A, mask with valve and filter. Option B, surgical mask. Option C, multi-layer cloth mask. Option D, N95 mask. So here the right answer is option C. CDC recommend general public should wear multi-layer cloth mask. They don't recommend surgical mask and N95 mask for general public because there is a shortage of these masks. There was a shortage. Okay. And option A is incorrect. We'll talk about that. So let's go to next slide and discuss this diagram. So on top, if you see patient index case, this patient when cough, patient who have COVID-19 infection, who have SARS-CoV-2, this patient can generate couple of type of particles. Number one, the blue one, these are bigger particle. They are like 20 micron. They can travel up to 6 feet. Number two is these green one. These are droplet. They are like 10 micron. And the smaller one are red. These are aerosol. Okay. So what happen if the same patient wear mask, whether surgical mask or multicolor cloth mask, multi-layer mask? With surgical mask or multi-layered cloth mask, the patient who have COVID-19 infection, who are either asymptomatic or mildly symptomatic, we can significantly decrease the amount of large droplet transmission. Now, if the exposed contact also wear mask, you can significantly decrease the transmission by droplet, typically more than 5 micron. However, the common mask, surgical mask and multi-layer mask, they cannot prevent infection with aerosol. We talk about aerosol is typically generated in the 14 procedure in the healthcare setting. Although aerosol can be generated in a patient in an elevator or closed room, the likelihood of transmission outside healthcare setting is a little bit low. But in healthcare setting, patients who have COVID-19 infection who are getting 14 procedure I mentioned in the last slide is very high. Okay. So let's go to next slide and talk about mask. Okay. So respirator are manufactured with different grade N95, N99, N100 depending on the percentage of 0.3 micron particle to be filtered out. So the N95 mask, it can remove the particle size up to 0.3 micron, 95% of the particles. Now, the virus size is 0.1 micron, and virus is very, very unlikely to be transmitted if the droplet is less than 1 micron. So that's why these N95 masks are so effective in preventing transmission from aerosol. Okay. So let's go to next slide and discuss comparison between surgical mask and N95 mask. Now surgical masks, they are fluid resistant. They provide protection against large droplet and splashes, whereas N95, they reduce exposure to smaller particle and aerosols. Face seal fitting surgical masks, they are loosely fit, and N95, they are tightly fit. Fit test requirement for N95 mask, usually we go to a lab and we get testing. You need a fit testing. You don't need fit testing for surgical mask. And user seal check requirement is required for N95 mask but not for surgical mask. Okay, so let's go to next slide and talk about that question. So first point was the mask. In this picture, if you see, general public should have a mask which have 2 or more layer of washable breathable fabric. That's point number 1. Point number 2, it completely cover your nose and mouth. Okay. Point number 3, it should fit snugly against the side of your face. It should not have any gaps. Point number 4, it should have a nose wire to prevent air from leaking out of the top of the mask. So these pictures I have taken from CDC websites. So for general public, CDC recommend these kind of masks. So let's go to next slide. What CDC don't recommend. CDC do not recommend exhalation valve or vent which allow virus to escape. And the second thing is CDC do not recommend mask made of fabric that makes it harder to breathe. For example, vinyl. Okay, so they don't recommend synthetic mask. So let's go to next slide and talk about another question. Question number 210. R0, R0 of COVID-19 is equal to R0 of measles. Is that true or false? This statement is false. Measles R0 is 15 to 18. COVID-19 R0 is 2 to 3. Common flu is 1.3. So let's talk about R0. What is that? Let's go to next slide. What is R0 of SARS-CoV-2 which causes COVID-19 infection? R0 is the average number of secondary cases from an average primary case in an entirely susceptible population. Goal is to keep R0 below 1. If the number stays below 1 for a sustained period of time, the number of new cases being reported each day should get fewer and fewer and fewer. Okay. Now, if in this table, if you see the R0 of measles is around 12 to 18, pertussis is 12 to 17, chickenpox is 10 to 12, whereas R0 of MERS, SARS and COVID-19, which is caused by SARS-CoV-2, is approximately between 2 to 3, okay? And common flu is 1.3. Now, the Delta variant R0 is equivalent to chickenpox, almost 8 to 9. That's why it's highly infectious, highly contagious. We'll talk about Delta variant in immunization section, okay? Question number 211. For adult who never develop symptom, isolation and other precaution can be discontinued 10 days after the date of their first positive RT-PCR test result for SARS-CoV-2 RNA. Is that true or false? This statement is true. So a patient who have asymptomatic COVID-19 infection, so the day you detect their positive PCR, from that day after 10 days you can discontinue their isolation and precautions, okay? So this is for patient who never develop symptom, okay? I think let's go to next slide and do question number 112. For immunocompetent patient with mild to moderate disease, the CDC says that infection control precaution specific for COVID-19 and home isolation can be discontinued when which of the following criteria are met? Option A, at least 10 days have passed since symptom first appear. Option B, at least 1 day 24 hours has passed since resolution of fever without the use of fever reducing medication. Option C, there is improvement in symptom. Option D, all of the above. So here the right answer is all of the above. So if patient is immunocompetent and if they have mild to moderate infection, if they meet these criteria, you can discontinue infection control precautions. So let's talk about this question. Let's go to next slide. Discontinuation of precaution in a patient with mild to moderate symptom, patient who are immunocompetent. Usually CDC recommend no test based strategy. We should not be repeating their test. Okay, so DC isolation, point number one, at least 10 days have passed since symptom first appeared. That's point number one. Point number two, at least 1 day 24 hours has passed since resolution of fever without the use of fever reducing medication. And point number three is there's an improvement in symptom, cough and shortness of breath. So if patients who are immunocompetent, if they are improving, they have no fever, 10 days after symptom onset, you can DC isolation. And CDC recommend we should not be repeating the test for these patients. Okay, we'll talk about that too in next section. Okay, when to testing strategy. So let's go to next slide and talk about discontinuation of precaution in a patient with severe or critical disease and immunocompromised patient with mild to moderate disease. Okay, so point number one, at least 10 days and up to 20 days have passed since symptom first appear. And point number two, at least 1 day has passed since resolution of the fever without the use of the medication. Point number three, there's an improvement in symptom, cough and shortness of breath. So here, patients who are immunocompromised, who have severe disease, studies have shown they can shed virus up to 20 days. But as the time progresses, keep on progressing, the viral shedding keep on decreasing. For immunocompetent patients who have mild to moderate infection, after 10 days symptom onset, if they are not spiking fever, viral shedding is negligible. The risk of transmission is rare. But patients who are immunocompromised, they can cause transmission up to 20 days. I want to make one more point. Studies have shown patients who are immunocompromised, if you do their antibody testing 2 weeks after onset of symptom, you might not detect antibody, but in immunocompetent patient, you can detect antibody within 2 weeks of symptom onset. Okay, it makes sense because patients who are immunocompromised, they still have virus, they are not developing antibody. Okay, so let's go to next slide and talk about test-based strategy to discontinue isolation. So point number one, resolution of fever without use of fever reducing medication. And point number two, improvement in symptoms, cough, shortness of breath. And point number three, negative result of SARS-CoV-2 from at least 2 consecutive respiratory specimens collected 24 hours apart. A total of 2 negative specimens. So this is a very important point. So let's say a patient who have a COVID-19 infection, they became symptomatic on day 2, and on day 5 they don't have any symptom, they have no fever, they are feeling great. Okay, they have recovered. You can do PCR on day 5 and then you can do another PCR on day 6. If both are negative, you can discontinue isolation a little bit sooner. Okay, so this is a test-based strategy to discontinue isolation in immunocompetent patients who have mild to moderate infection. Let's go to next slide and talk about how to quarantine unvaccinated patients. You quarantine when you might have been exposed to the virus. CDC recommend that patients who have not got vaccination, we should quarantine them for 14 days. Now, patients who have been exposed to COVID-19 patient who are unvaccinated, if they are tested positive, you can discontinue their isolation after 10 days. But if you don't test them, if patient have no symptom, unvaccinated patient who have been exposed, you quarantine them for 14 days. So if you test somebody, if they are positive, you stop the isolation in 10 days. Okay, so let's go to next slide and do one question. Question number 213. A fully vaccinated immunocompetent patient had a dinner with his unvaccinated friend. His friend tested positive next day. This patient come to you. What would you recommend for your asymptomatic immunocompetent patient? Option A, isolate for 10 days. Option B, testing should be done 10 to 14 days following the date of exposure. Option number C, ask him to wear a mask in public indoor setting for 2 weeks. Option D, none of the above. Here the right answer is option C. You're going to ask him to wear a mask in public indoor setting for 14 days or until they receive a negative test. Option A, this is incorrect. We isolate vaccinated patients who have mild symptom for 10 days. If they are asymptomatic, you do not isolate them. Option B is incorrect. Testing should be done 10 to 14 days following the date of exposure. This is incorrect. If you are offering testing to vaccinated person who have been exposed, ideally it should be done within 3 to 5 days. So with this, we are done with this section. In next section, we're going to talk about clinical manifestation of COVID-19 infection. We'll also talk about spectrum of severity. We will talk about how to manage COVID-19 patient in an outpatient setting. So I'm going to stop it here. Thank you.